territory of V1, or the ophthalmic division of the trigeminal nerve, which starts from the middle of the scalp there, all the way down here, the entire forehead, the eyes, and the tip of the nose, and the really the upper lip would be part of V2. So all of this is V1. V1 territory is big. V2 starts really below this line. I imagine someone wearing eyeglasses once again, and it's sort of, if you draw a line from the tragus all the way to the angle of the mouth, it's a small area. It ends up being a small area just like that. And V3 is just below in this area. It's sparing the angle of the mandible, which is supplied by spinal nerves. It's not supplied by the trigeminal nerve. So what you would do, you keep this division in mind, and then you would ask the patient to close their eyes. يوسف حاسس شيء؟
ايه
ايش حاسس؟
لمسة خفيفة في اليسار.
هنا زيها؟
ايه لمسة.
You're comparing right to left. If there's a, God forbid, a stroke or something, you would there would be a difference. ما في فرق بينهم صح؟
نعم.
And then you compare different divisions. هذا ده زي بعض؟
ايوه.
وده زي بعض.
ايوه.
صح؟ So again, comparing right and left. وده زي بعض؟
ايوه.
واحد اثنين.
ايوه.
وده زي بعض.
ايوه.
وده زي بعض.
ايوه.
So we compared across sides and the three divisions to each other. So once again, it's easier to remember that this is V1, this is V2, this is V3. One can do the same thing with pinprick, but it's often not necessary. So that's the sensory part of the trigeminal nerve. That's what you need to know. You ask the patient to close their eyes, and use a clean piece of cotton or tissue, and you compare sides and compare divisions. There are two reflexes in relation to the trigeminal nerve. One is the corneal reflex, which is you touch the cornea with a clean piece of, again, cotton or tissue, and what the person is supposed to do is they're supposed to close their eyes bilaterally, reflexively, obviously, not voluntarily, and they would feel the piece of tissue touching their eye. So يوسف المنديل حيلمس عينك ما راح أعورك كثير حتحس فيه. طول هناك كده. So I'm going to do the right eye. So I asked the patient to look laterally, and I basically touch the sclera. I'm touching the right eye. So what Yusuf is doing now is reflexive. So once again, it's reflexive. So I'm going to make it a little smaller so that it's less uncomfortable. So this is all voluntary, whereas this is the reflex. So by touching the sclera first, you're able to know what the difference between what happens reflexively and what happens voluntarily. And you do it with the other eye. Are you okay? You're good? Okay. So, what you want to touch is the cornea, which is the transparent part behind which you see the iris. You want to touch the sclera only to know, to help you recognize the reflex and recognize that it's not voluntary. The corneal reflex happens when you touch the cornea with the stimulus. And with this, really, we have ended demonstration of the corneal reflex. There's another reflex relating to the third nerve, to the fifth nerve, that we will demonstrate later on. So moving on, we've done 1, 2, 3, 4, 5, 6. Moving on to cranial nerve number 7, which is the facial nerve. The bulk of the function of which is mainly motor. So يوسف سوي كده بعدين أسنانك أكثر شيء أيوه بعدين أرتاح غمض عينك مرة جوا كأنه فيها صابون غمض عينك مرة جوا, and you would sort of dry them open. أفتح عينك تمام وأرفع حواجبك على فوق. Okay, جميل. نسوي كده. Okay, بعدين shrug كده أرفع عيني رقبتك على فوق كده جميل. So these are the components of the biggest muscles in the face. And the facial muscle is important. The facial nerve is important for facial expression. So we've done orbicularis oculi, orbicularis oris, orbicularis oculi, frontalis muscle by raising the eyebrows, buccinator, and platysma. The facial nerve is comes out of multiple nuclei. The facial motor nucleus is in the pons, and it has the lower motor neurons that control movements of the face. And each side of the face, or each of the two nuclei, gets upper motor neuron innervation. Just like with the rest of the body, there's a lower motor neuron and there's an upper motor neuron. The upper motor neuron comes from the cortex, from the motor cortex. The lower part of the face, meaning the orbicularis, oris, the buccinator, receives upper motor neuron from the contralateral hemisphere, meaning the Yusuf's right facial motor nucleus receives its upper motor neuron from his left hemisphere. Yusuf's orbicularis oculi and frontalis receive upper motor innervation also from the contralateral hemisphere, but as well as from the ipsilateral hemisphere. So when there is a lesion in the right hemisphere, the lower part of the face on the left side will get affected, because that's the only place where it gets upper motor neuron innervation. Whereas the upper part of the face will not be affected, because it receives upper motor neuron innervation from the left hemisphere as well. So in other words, what students and what we all should remember is that an upper motor neuron facial palsy will affect the lower part of the face only, whereas a lower motor neuron facial palsy will affect both upper and lower parts of the face. This really concludes the major part of the facial nerve testing. The facial nerve also supplies taste to the anterior 2/3 of the tongue and some other minor sensory functions, but these are not routinely tested. So moving on to the 8th cranial nerve, the vestibulocochlear nerve, which is concerned with balance and hearing. So people use the Rene and Weber test, but we will not demonstrate them in this video. What we often do in the clinic is we do something like this to test hearing. إذا غمض عينك، إذا سمعت شيء قول لي فين سمعت، يمين ولا يسار؟ So Yusuf was able to tell me where he heard. So subtle stimulus with finger rubbing. People sometimes whisper in one or two of the ears and see if hearing is generally okay. Really, further testing of hearing should be is just better done in the ENT clinic. So that's hearing, and the 8th part is also important for balance, it's tested when you test gait. It's important for eye movements, and it's tested when you test eye movements. And what you might see if there's an 8th nerve lesion, or if there's an inner ear lesion, you would see nystagmus, which is jiggling of the eye with a slow phase and then a fast phase of the eye, or the eyes would sort of jiggle like that. So these are the most important parts of the 8th nerve. So what you do is the confrontation hearing, if you want, and you observe for nystagmus. There are other tests that are, again, not for the purposes of this video. Cranial nerves number 9 and 10 are tested together, and they have to do with the nasopharynx. So what I would do is I would ask Yusuf to open his mouth, with ah, and I'm looking at his soft palate, with ah, and I see that his uvula has elevated. So his uvula, when he said ah, his soft palate contracted and his uvula rose in the middle. And this is the function of mainly the 10th and partly the 9th nerve, 9th being glossopharyngeal and 10 being the vagus nerve. And say there's a lesion, a lower motor neuron lesion in the vagus nerve on the right side. Well, what's going to happen is that the left side will work, and when the patient says ah, the uvula will be drawn towards the working side, away from the side of the lesion. So the uvula is like that, and they'll be drawn away from the side of the lesion. So it's something to remember. And then the other part, which we will not demonstrate, but it's pretty easy, is the gag reflex. So what you do is you just take a tongue depressor, you ask the patient to open their mouth, and you sort of go all the way, and you observe the patient's gagging, and you ask if they actually felt the tongue depressor hit the back of their nasopharynx. So that's cranial nerves 9 and 10. Cranial nerve number 11, the spinal accessory nerve, is pretty easy to demonstrate. So Yusuf, طول يمين وثبت راسك زي كده. So now I'm testing the left sternocleidomastoid, the left spinal accessory nerve. طول الجهة الثانية وثبت راسك زي كده. Now the right sternocleidomastoid. ريح راسك. ارفع كتافك على فوق كده وخليهم على فوق كده. So this is the trapezius muscle. So that's it. We're done with the 11th cranial nerve, the spinal accessory nerve. Cranial nerve number 12 is the hypoglossal nerve. So what you do is what you do first is you ask the patient to open the mouth and you look at the tongue. You look to see if there's atrophy, difference from side to side, and if there's fasciculations, which are very small movements in the tongue, which are a sign of lower motor neuron lesion. So you should sort of observe for 10 seconds, 15 seconds, and then you ask the patient to so what happens is that both sides of the tongue are pushing equally, so the tongue extrudes in the middle. If there's a lesion in one side, the strong lesion will push it. So the tongue will deviate towards the side of a lower motor neuron 12th nerve palsy. So do not confuse that with what the uvula does. The uvula does the opposite. And the last thing we want to demonstrate is the jaw jerk or the jaw reflex. So what you want is a reflex hammer, and you ask the patient to open the mouth slightly. And you put your fingers on the jaw, and you basically just tap on it. The jaw jerk is not present in most people, or is very mild. So if the person has an exaggerated jaw jerk, their teeth would sort of hit each other like that when you hit with the tendon hammer. So what you want to do is, first of all, once again, so open your mouth. Yes, if you open their mouth slightly, you put your finger, do not hit the chin or the jaw, and you sort of hit like that. And this is normal, and if it's exaggerated, the jaw will sort of, the teeth will hit each other. That's an exaggerated jaw jerk, sign of pseudobulbar palsy. And this really concludes the examination of the cranial nerves from 1 to 12. We can stop. On to the third component of the neurological examination, the motor exam. The motor exam starts with inspection of the person's posture on muscles and if there are abnormal movements, moves on to tone, muscle tone, then to muscle power, and then to different reflexes, deep tendon reflexes and superficial reflexes, and the plantar responses on both sides. So, starting with inspection. So if you want to examine the motor system, you would want to basically have the patient dressed down, and you would want to focus on each area, looking to see if there's, for example, muscle atrophy, looking at the hands. This is the thenar eminence, seems full, hypothenar eminence. There's no muscle atrophy in some people with lower motor neuron lesions or people who are cachectic. You'll see sort of farrowing here between the metacarpophalangeal joints. The forearm looks full, there's no atrophy, there's no scalloping. You would want to also look at the deltoid, see if there's a natural curvature that one would see with a deltoid. You would want to look at the calves and so on. Atrophy or loss of muscle bulk is a sign of a lower motor neuron lesion, which means that it's not something that's happening in the brain or spinal cord usually. Atrophy does happen in upper motor neuron lesions, but only after a long period of not using the affected part. So it's called disuse atrophy. But generally speaking, atrophy is seen in lower motor neuron lesions, not immediately, anyways, in upper motor neuron lesions. The other thing you want to inspect for is something called fasciculations, which we talked about earlier when we talked about cranial nerve number 12. You can see them in the tongue. One can also see them in the periphery, so with a lower motor neuron lesion as well. So you sort of inspect the muscle carefully for very small quivers in the muscle. So either here in the forearm, people often look here in the hands. So the abductor pollicis brevis muscle, and on both sides, and you sort of stare at it. People will also look at the calves and the quads, the quadriceps muscles, and you sort of stare at it. You want to have good lighting. Sometimes you'd even want to have the flashlight, and you sort of have it at the aimed at the muscle, and you want to look carefully. There are other things that you can inspect for, such as if there are skin stigmata of any of neurocutaneous syndromes, if there are signs of trauma, for example, if there are rashes in some of the muscle disorders like dermatomyositis or other autoimmune diseases that can cause rashes and so on. So you want to inspect for all of that. Posture, is important. So people who have flaccidity, whose muscles are flaccid, will tend not to move that part of their body. And for example, if Yusuf is lying down, and if a patient, one of his legs are not moving, it'll be externally rotated. You'll see the feet, one of them is sort of externally rotated. In upper motor neuron lesions that are chronic, the extensor muscles become weaker in the upper extremity, so the flexor muscles take over. So the wrist will be flexed, the elbow will be flexed, and sort of it will be adducted like that. So people with remote strokes, for example, you see them walking in the street sort of in this position. But we don't see any of that here. We see someone who's sitting comfortably with no posturing of any kind, and no abnormal movements. So there are specific maneuvers to test for, to use when testing for tremors, for example. So we don't see any tremors at rest. One can ask Yusuf Sokida, and one can sort of observe closely from a profile kind of view from the side. One can put a paper on top of the hands to see if if one side quivers more than the other, or both sides quiver, and so kida. So that's the test for asterixis. If there were asterixis, people would sort of do like that irregularly. So this way you're sort of comparing one hand to the other hand. So all of these are various maneuvers one can look for tremors for, in addition to rest. So people with Parkinson's disease will have tremor at rest, and when they're distracted and the arm is not doing anything, they'll start having the classic pill rolling tremor. Whereas these other maneuvers will bring out tremors that are called not rest tremor like Parkinson's disease, they're called kinetic tremors or action tremors. This includes a category of essential tremor, enhanced physiologic tremor, thyrotoxicosis, for example. Beta agonist medications can cause that, for example. And finally, action tremor with cerebellum. So we'll demonstrate cerebellar testing, but we can do finger nose testing here to demonstrate that it's part of if you're evaluating tremors. So Yusuf, المس إصبعين، المس أنفك، تعال هنا تاني، روح أنفك تاني، تعال هنا، روح، تعال. So a person with tremors that has past pointing will kind of overshoot and come back and overshoot, come back and overshoot, and will sort of have a trajectory kind of like that before reaching the finger. So this is another maneuver. It's part of the cerebellar exam, but it's also used. It's helpful when you're looking for cerebellar lesion, if you're looking for evaluating someone with tremors. So after inspection, you move on to muscle power. So it depends the level of scrutiny one wants to give to the muscle power exam depends on what you're looking for. But I'm going to demonstrate the general muscle power exam that people will want to do in the clinic. So you basically take one joint at a time, and you see what it can do at against gravity and then what it can do against resistance. So Yusuf so what I'm seeing now is that Yusuf is able to lift or work or use his deltoids to work against gravity, which is graded as power 3, at least 3. If I apply resistance, it means it's 4, and if I apply maximal resistance and I'm not able to overcome him, then it's 5. So now it's 3 on the scale, and now I'm applying resistance. So now it's 5. So I'm testing now his elbow extension. دفني على الربع. And دفني على الربع هنا. اسحبني عليك. Biceps, brachialis. اسحبني عليك هنا. Okay. So now I can grade all of these as 5. So إذا كده. Wrist extension. That's 5. Then notice that I will use my own fingers. I will not use my entire pectoralis major, for example. If I do this, I'm going to overcome him no matter what I do, but the more appropriate way to do it is to use your fingers. وبعدين دفن كده بصباعك هنا. Yep. Okay. Good. And notice that I'm doing the same muscle on the right and then on the left to compare, because at the subtle weakness you won't see it unless you compare both sides. And then you can do you can do the finger flexors on both sides. If you really wanna, you can spend an hour examining just the small muscles of the hand, but I'm showing you the most important muscles. This is the abductor pollicis brevis, which is the movement of which is like that, compared to like this, which is the adductor muscle. So this is abduction, this is adduction, this is obviously extension and abduction. So this is general, the general way to test the muscles of the upper extremities, and we'll do the same with the lower extremities. Yusuf, رجلك هترفعها فوق زي كده. Hip flexion خليها فوق. That's 3, and now it's 5. الجهة الثانية 3, and now it's كمان قومي 5, and now knee extension. دفني على برا. Quadriceps, that's 5. Hamstrings, knee flexion. اسحبني على ورا. That's 5. هنا. اسحبني على ورا. Okay, so that's, again, you compare both sides. Where now the foot dorsiflexion. يوسف ارفع رجلك على فوق كده. ايوه عليك وخليها زي كده. And you try to push it down, and you want to use really a good power exam makes you tired. So that's 5. ودفني على تحت. على تحت ايوه ايوه خليه زي كده. Okay, all right. صباعك الكبير على فوق, extensor hallucis. Okay, الجهة الثانية شو؟ على فوق. So if I had the slightest suspicion, I would do dorsiflexion, dorsiflexion, plantar flexion, plantar flexion to compare. نزل على تحت. خليك زي كده. بعدين إصبعك الصغير على فوق. That's very good. And ideally, if you want to do the exam in its full way, you would have the patient take off their socks, which you might do later on. Now, pitfalls. First of all, you want to test one joint at a time. So if I want to test shoulder abduction, it would be wrong to do this, to put it on the forearms, because this way you're testing a lot of muscles. But if you do it right here, you are testing just the shoulder abduction. Another pitfall is do not start like that. Just do not start like you say push out, because this way you would not know. You want to get the power to get to B3 first, and then you would apply resistance. So do not start with resistance immediately. Okay. So third pitfall, do not test the joint at its full, at the end of range. So So you want to test elbow extension, don't do this. Don't do that. You're putting, you're putting yourself or him at a disadvantage if you do this, or if you do this. Do not test elbow extension. No one will be able to overcome this. No? So he will never be able to overcome it. So you want to test the joint in the middle of the range of motion. Not like this, not like that. Okay. And then the remaining parts are come with experience. So you will be able to know how much power is acceptable from a particular individual. But the most important part is that there shouldn't be asymmetry from side to side. So the last part of the muscle power examination that I want to demonstrate is what's called drift maneuvers. These are sort of functional tests that bring out subtle movement that might not be detected otherwise. So you حط ايدينك زي كده وخلي اصابعك مع بعض. That's how I do it. غمض عينك. And you just wait for 30 seconds, and the normal response is for the hands to stay in the same sort of position and posture, the arms as well. And if there is a problem, what Yusuf would do, what would happen is that there would be loss of finger extension, would be cupping of the fingers, cupping of the hand, and then it would pronate. It's called pronator drift, and then it would sort of drop down. This would mean that there's a slight or subtle weakness